I'm going to speak to you regarding whether SU is the old molecule, but still the golden molecule. I'll discuss the current positioning, but the bottom of the day, at the end of the day, I'll try to show you the slogan that we have given from the International Task Force that sulfonylureas, modern sulfonylureas are cardio safe and glucose smart, very relevant to today's discussion. I base my case with 7 points. Number one, I'll show its glycemic efficacy 1.5 to 2.5 and beyond compared to glycemic efficacy of the modern molecules 0.6 to 0.74. It is safety and CBOT comparison with linagliptin, which has given its place of pride. I'll go through the cardiorenal benefits. Most important, the socio-economical aspects. And today, I call it a molecule of the 4 A's. Most affordable, most appropriate, easily available, and easily accessible. That is the molecule sulfonylurea, the old molecule, still the golden molecule. We'll try to see the fear of hypoglycemia. It does occur, no doubt, but how severe it is, whether we can manage it, the weight gain fear, and also allude to the Carmilla trial. And most important, I go to legacy effect. It has been said that sulfonylurea is a classic in the diabetes therapy, like Ramayana and Mahabharata. In a lighter vein, don't take it seriously. The current molecules may be at the best Chetan Bhagat's half-girlfriend. I'm telling you lighter vein. So it has a great legacy effect of molecular memory, which the other molecules take another 10 years to prove, and widest global acceptance. I have taken out the slide to save time. The acceptance is between 40% to 56% all the world over. I'll draw your attention to 3 things. The diabetes in India has 3 challenges: suboptimal control, limited healthcare, and high cost of the disease management. And this shows the huge hyperglycemia that we have. This from the ICMR in-dab data just concluded. I am the chair for that study today. And I must tell you, the average HbA1c in the best of the conditions is between 8.7 to 9.4. So we have great hyperglycemia. And consequent on that, we have the macro and the microvascular complications. Therefore, we must use a drug as the second line next to Dr. Parikh's metformin, which has good glycemic control and quality of life compared to those associated with other agents. The regimen in sulfonylurea, I'll show in a minute, my dear friends, has shown the longest time to insulin dependence. So it has the longest glycemic durability. Dear friends, why it is preferred first add-on to metformin as the golden molecule? It targets 2 pathological defects with metformin and modern issues are given. Cost-effective, very potent efficacy, long safety history, weight neutral, and I have shown the weight neutral studies. If at all, weight gain can be easily managed and improves the patient adherence. This is our publication from the International Task Force. We said the sulfonylureas in oral combination therapy is wonderful. Comparative assessment as dual therapy with metformin. Special situations, it has been used, elderly population and with CKD and etc. I'll come in a minute. Used in comorbid conditions, and of course the BITS therapy, the bedtime insulin and daytime sulfonylurea therapy, the combination therapy. This is the continuum of type 2 diabetes mellitus. Dear friends, I must carry home the message that this drug is indicated newly diagnosed type 2 diabetes, uncontrolled with high HbA1c, obese and overweight. It is with CVD and HF with the current Carmilla trial, with CKD, elderly who have risk of hypoglycemia. Dear friends, I'm alluding to modern sulfonylureas, which includes glimepiride, glycoside MR, and glipizide. And long-standing type 2 diabetes mellitus went on insulin. Now coming to the uncontrolled diabetes, metformin and sulfonylurea as the initial combination of therapy recommended by IDF when the HbA1c between 7.5 to 9. The NICE guideline says the first intensification must be sulfonylurea if HbA1c rises above 7.5. There is a comparison, my dear friends. See, DPP-4 plus metformin, the second best combination, second wide combination used in our use today, metformin with DPP-4. But this combination, metformin sulfonylurea, better and more durable glucose lowering efficacy. Pio plus met, Sachin spoke beautifully. The good glucose lowering effect with significantly lower risk of weight gain. He also said about that. SGLT2 and metformin is non-inferior to this combination for the glycemic control. GLP-1 RA and metformin, similar glycemic efficacy with acceptable safety at lower cost. We'll come back to the recently published great trial of ADA in a minute. Now, if you evaluate the safety and efficacy of glimepiride with sitagliptin, as done by our colleagues and Venkatraman and others and published, the modern sulfonylureas like glimepiride are still important second-line drug and better than this sitagliptin for producing better glycemic control. Now, if you look for the durability in the routine clinical practice, adding DPP-4 to metformin associates with increased earlier requirement of treatment intensification. There's no head-to-head comparison of the verified trial with the sulfonylurea metformin combination. We have some indication from the GREAT trial, but it's compared to that, sulfonylurea gives a greater durability of action. And this is a slide which shows the greater durability of SU plus metformin compared to SU metformin plus DPP-4. Now, this also about the weight gain. This is a very simple study. No significant difference in the metformin plus glimepiride group compared to the other groups that was used as a study for 5 years, and have shown the BMI. Strict glycemic control must be maintained with sulfonylurea metformin in the real life setting without relevant weight changes can be done. And look at the BMI published in the study, START study, and you will find that the BMI with the glimepiride metformin and sitagliptin metformin are almost similar. Dear friends, coming to the Corona trial, both the MACE, HHF, and renal events were comparable with linagliptin. And to make a long story short, I'll just quote Rosenstedt that glimepiride is at par with linagliptin in terms of time to first occurrence of the CV death, non-fatal MI, and non-fatal stroke, and in a type 2 diabetes mellitus patient at high severe risk, global study, and followed for a long time, the 6 years. And this was presented in 2019 EASD. And you know, the association between the sulfonylurea and the all-cause mortality and cancer mortality beautifully shown here. You see the total mortality, and you will find that the cumulative mortality and the cumulative dose, you find all-cause, cardiovascular, MI, and stroke all are in favor of the sulfonylurea. So this is a wonderful drug for all-cause mortality. Dear friends, if you come to the IDF guideline, it has praised metformin, and next to metformin, it has recommended sulfonylurea as a CV event neutral, CHF neutral drug. And you know, the modern sulfonylureas probable reason for CV safety are three. Number one, does not impair the preconditioning, ischemic preconditioning. It is weight neutral and less of hypoglycemia. And you know, modern sulfonylurea like glimepiride does not inhibit the mitochondrial K-ATP channels in the heart. Therefore, the IPC is preserved with glimepiride. Dear friends, coming to the last part with CKD and elderly patients, you will find that elderly can be used this modern sulfonylureas, not the old ones like glibenclamide, because these are low risk of hypo compared to the old sulfonylureas, preferably at a lower dose in the renal impairment. And during Ramadan, it can be used with appropriate counseling and with dose modification. Now, there is significantly low dose glimepiride, 0.5 is available today. And in various FDs, the low dose glimepiride provides maximum efficacy with few adverse effects. As you know, the OHs perform better with a submaximal dose. So low dose combination therapy have fewer side effects, achieve better glycemic control and additive clinical benefits. Therefore, the low dose is indicated in all these indications. Now, last but not the least, that sulfonylurea do not have any harmful effect on the beta cell function. Diabetes itself can cause decline beta cell function. So SU has been used for a long time with the combination with other OADs and with insulin called BEATS therapy. And this showed one of the studies of premixed human insulin plus sulfonylurea producing better glycemic control. So insulin with glimepiride can improve glycemic control, published 2 years back. Therefore, modern sulfonylurea is an integral part of the type 2 diabetes management and to be considered for use in combination with all class anti-diabetic drugs, specifically except glinides. And all the FCDs with SU, metformin, triple drug combinations are available. Their convenience, people are compliant, and they provide clinical efficacy. Dear friends, the last part, if you are asked what is most important, most fearful for a patient, other than the disease, the cost of the treatment. Indian patients are brand conscious, the new drug conscious, at the same time, they're cost conscious. And 70% of the patients pay out of pocket or go to the government facility. Glimepiride is provided in all the primary health centers and 600 district hospitals free of cost in my country because it is very effective. I must tell you that if you look to the cost gain, it's about 30 rupees a day compared to original SGLT2 inhibitors and the DPP4 combination. We save about 18 to 16 rupees a day. Cost, we save about 30 rupees a day. On a year, about 11,000. And this can be plowed back for the other drugs that we use, like statin, aspirin, RAS blockers. So, routine investigations, the checkup cost, the consultation cost. So, it's the best cost saving. So, I will end by saying the latest article in the Lancet.
1 minute left, sir.
I have finished, sir. Diabetes endocrinology. Does sulfonylureas still have a place in clinical practice? The answer is yes. My friend Kamlesh Khunti wrote in the Lancet in 2018, because of the robust evidence base, very cost effective, potent glycemic action, cardio safe and glucose smart, durable glycemic control, weight neutral, and low risk of hypoglycemia. Therefore, issues is a golden molecule, clearly have a place in the care of the type 2 diabetes management, an important part of the armamentarium. I do stop here by just explaining the opinion that all the drugs have their benefit. And sulfonylurea is, people said they're going to write obituary about sulfonylurea, but sulfonylurea is still a golden molecule, cardio safe, glucose smart, and affordable, appropriate, accessible, and available. Thank you very much for a patient hearing.